Hello, everyone. Wonderful to be here. Thank you for having me. So today, again, my name is Emily Schaffer. I'm a fourth-year medical student from the University of New England College of Osteopathic Medicine. I'm going to be presenting on behalf of Bay State Medical Center and the entire research team there in the emergency department. Our project is entitled A Qualitative Evaluation of Barriers to and Facilitators of Starting Buprenorphine in the ED. First of all, I have no relevant relationships to disclose. So as far as our background and objectives for this study, buprenorphine is a well-known medication that decreases the morbidity and mortality associated to opioid use disorder. And despite this overwhelming evidence that exists, it's still widely underutilized in the emergency medicine setting. And so our goal was to, first of all, identify what are the barriers to and also the facilitators of providing buprenorphine in the ED so as to improve the implementation of buprenorphine prescribing in the emergency setting. As far as our methods, so we conducted semi-structured interviews with multiple emergency medicine providers throughout the United States. We did then take these interviews, record them, transcribe them, and then code them using a code book that was developed by the Consolidated Framework for Implementation Research. This study was qualitative in nature. And each transcript was ultimately coded using a final codebook that was consolidated. As far as our demographics, we did interview 25 different providers, mean age of 43. They were from 11 different states and worked at 25 different hospitals. So as far as our results, common barriers that were identified, I mean, you can see on the slide that there was a number of different barriers that were brought up, but it was interesting that throughout these 25 conversations, we did find commonalities between what the providers were telling us. So one thing that came up was the waiver process associated to prescribing buprenorphine. Providers had concerns over time, money, the availability and accessibilities of follow-up resources were another major concern. Some providers were outright distrusting of patients who had opioid use disorder and experienced almost a degree of stigma towards these patients. There was lack of beliefs in the complexities or training as far as starting buprenorphine, just feeling not confident overall, as well as concerns in the actual safety of this medication. Are we going to be causing precipitated withdrawal in these patients? Is there some concern for overdose when using buprenorphine? And of course, there were also logistical challenges that came up. We wanted to share some quotes from some of the providers that came up as far as the common barriers. So one quote, "How much is buprenorphine being abused? Are we enabling patients? Can we really trust them? Is it really something we should do because then all of the drug addicts in the country are going to come to us? Are we actually making a change in that person's life? I still think we're just putting a Band-Aid on it. It sounds bad, but if it takes longer to have that discussion with someone than it takes to run a STEMI, then it's not as exciting in the mind of the average emergency physician. I don't understand how it's different than other opiates. I don't know much about the pharmacology, but it's another opiate that causes physical dependence and withdrawal." On the other end of the spectrum, common facilitators, it was interesting because they were almost the parallel to the barriers that we had identified. So facilitators for prescribing buprenorphine in the emergency setting were free X-waiver training, or if the facility made this mandatory or even tailored to the emergency setting. Similarly, having accessible and available resources for follow-up for patients with addiction resources, that was something that was very important. Having a peer champion was also something that was seen as helpful, someone that really stepped forward to educate providers and guide them through this process of starting patients on buprenorphine. Some providers really felt a moral imperative that this is my job to do this and that I need to step forward and it's important to address this. And similarly, and really embracing the disease model of addiction, just combating stigma overall. Protocols and algorithms were another thing that were effective in facilitating the use of buprenorphine. And influencers, conferences, talks just like this one were another commonality in facilitating this use of this medication. So quotes, "Whatever harm you think you can do with Suboxone, think about the harm they can do to themselves with IV heroin." By getting them on Suboxone and bridging them to that next appointment, you can save their life. It's the job of the ER, just like connecting them to the cath lab. It's akin to saving their lives. These people are going to die. I have a strong potential to save some people, young people who have the potential to be good parents and functional parts of society. People on Suboxone are being judged by a lot of the medical community, physicians, pharmacists, nurses. They're looked at being addicts. But I would say, think of this like a diabetic who needs insulin. This is like their blood pressure medication. I try to remove that sense of stigma, that sense of shame. So in conclusion, we found that there was notable variation in different providers' attitudes about prescribing buprenorphine in the emergency setting. And you saw many examples on both sides of the spectrum. Those providers that had more experience really with dealing with this up close did provide more concrete implementation strategies. So thoughts on what to do next as far as solving this problem. And many themes were seen as two sides of the same coin. You saw some providers that saw something as a facilitator, whereas others saw that same aspect as a barrier. However, implementation strategies for prescribing buprenorphine in the emergency setting should address attitudes, training, follow-up, and logistics, as well as those aspects that we did bring up. And in conclusion, who is going to start buprenorphine if we don't start it? I just wanted to thank everyone on behalf of the Bay State Medical Center Emergency Medicine Research Team for attending this.